Hello, my name is Tay White. I was really excited to actually make this video for you guys because it encompasses everything I've learned so far in college. I'm a senior now, so it was fun to put all of my knowledge together from anatomy, botany, cell molec, biochem. It was really interesting to see all of it play together as I prepare to go to medical school. So let's just take a look at the effects of medical cannabis on patients with bipolar disorder. So what is bipolar disorder? It's a mental illness associated with episodes of mood swings ranging from depressive lows to manic highs. So these can last days, which is rapid mood cycling, or up to months, up to years. And these are usually the longer depressive symptoms, which can be associated with suicidal thoughts and even attempts. This is a chronic condition with no cure, just treatments and therapies to try to alleviate the symptoms. Sometimes these symptoms can actually be so bad that they disable people from working, and it's actually included in the Social Security listing of impairments. So these symptoms can be so debilitating that people are just stuck in their house and they can't even do much for themselves. Previous fMRI studies show that functional and structural differences of the brain occur in those with bipolar disorder. So functional magnetic resonance imaging measures and quantifies activity in the brain based off changes in blood flow. So it actually lights up and shows you where there's higher levels of activity or lower levels of activity. And many of these studies have been recently done, and they've identified different areas of the brain that were significantly less active in patients with bipolar disorder than they were in healthy individuals. These areas include prefrontal, temporal, and posterior parietal cortices, cortical limbic system, and visual cortex and sensory processing areas. So these are some huge areas of the brain that can really make an impact, which can explain why some of these symptoms are so drastic. So this picture here from Borgel et al. Shows areas of low activation. You can see up here in the corner, the temporal areas, posterior. So I just think this image is really cool. It's a good visual of where these areas are. And it kind of is all over the brain. This next image from the same group shows the functional differences in a brain with bipolar disorder. So this is showing the connectivity between these different regions. So traditionally, bipolar disorder is treated with pharmaceuticals. Unfortunately, these are not 100% effective and can actually have pretty bad side effects. Some of those are listed down here for some of the most common pharmaceuticals. Lithium can actually build up to a toxic level in the body and can then cause mania and withdrawal whenever you have to take them off of that. A lot of common antidepressants cause high moods, which can then lead to the rapid mood cycling. Lamotrigine, which is one of the most common medicines for bipolar disorder, can actually result in a life-threatening skin condition. And sodium valproate may damage reproductive viability of childbearing-aged women. So that's not even an option for women. Doctors won't prescribe that to women because of that harmful side effect. So honestly, almost 30 to 40% of patients are not consistently helped by these treatments, either because of the side effects or they build up a tolerance or dosage just can't be correct. There's a multitude of reasons, but there's just a lot of issues still with these treatments, which is why cannabis is being looked at as a treatment because there's a need for something new. And as many people are trying to shy away from pharmaceuticals, medical cannabis is a good option, especially with the discovery of the endocannabinoid system. It was discovered in the 1990s as a regulatory apparatus connected with nearly every physiological and pathological aspect of mammalian biology. It's a crucial moderator of the autonomic nervous system and plays a part in controlling both excitatory and inhibitory neurotransmission. It works by receptors, CB1 and CB2. They are G protein receptors. They were originally found concentrated in the central nervous system, but since then the CB2 receptor has been found all throughout the body. The CB2 receptor, since this discovery, has been an area of interest. Recently, there has been genetic evidence to suggest that this receptor could actually influence the pathogenesis of bipolar disorder. So I think that this is a really interesting link between these two topics, that this polymorphism, so this genetic mutation in patients with bipolar disorder, in which the 524th amino acid in the protein encoding for this CB2 receptor mutates from C to A, that leads to just decreased expression of these receptors. So people with bipolar disorder have this genetic mutation and then have less expression of the CB2 receptor. Another preclinical study showed that the complete genetic deletion of this receptor would actually result in depressive-like behavior in mice. So this shows that if you get rid of this receptor and these become imbalanced, and the natural ligand, which is a lipid-based retrograde neurotransmitter, can work in harmony the way it's supposed to, this is what a lot of people refer to as that chemical imbalance for bipolar disorder. So how does THC play a part in this? THC actually acts as a weak ligand on these receptors, with known effects on pain, appetite, digestion, emotions, and thought processes. So that explains the wide-felt effects when you consume cannabis. But it also acts as a blocker for the 7-transmembrane receptor and distorts its signaling property. It's found on every cell. And stimulation of these receptors, either by the endogenous ligands or by THC, increases microglial stimulation and decreases inflammation. That sentence right there is a big part of my hypothesis, and just thinking that stimulating these receptors will increase this brain activation and stimulation. My hypothesis states by stimulating the remaining expressed receptors with THC, depending on the administration route, it would be seen on fMRI that levels of activation could be similar to someone without the disorder. If this is seen, it could be concluded that cannabis is a viable treatment option for those with bipolar disorder that extends beyond placebo and anecdotal evidence. To test this, the independent variable would obviously be the consumption of THC. I'm going to do it through different administration routes. These administration routes would be smoking or vaporization, oral, and topical. I skipped oral mucosal just because it's not very common. Not a lot is known about it, even less than all the others. It's further hypothesized, though, that the vaporization will have the greatest effects on brain activation and topical creams will have the least effect. This is mostly because of the onset and duration, plus the pros and cons, which can all be seen down here in figure 3. Smoking or vaporization has fast onset, and it has an advantage for acute symptoms. whereas topical is more variable and has a less systemic effect. For this experimental plan, the topical will be applied right to the back of the neck to be as close to the brain as possible without being in the hair. To control for each of the different treatments, they will all be the same THC composition. They'll start with 2.5 milligrams and increase by 2.5 milligrams every day until 15 milligrams or as tolerated. I got these numbers from a study I read, which was pretty interesting, and it stated that this is a good way to start as like a slow and steady kind of way to gauge one-time use versus daily use effects, and I think that's a really good idea. So to gauge the effects, the dependent variable will be levels of activation in those previously identified regions in the brain. They will be measured through the fMRI, so we will get pictures like we looked at before. All the patients will get both the resting state and task-based fMRI as a baseline, just because individuals' brains vary significantly, and we need to make sure we see where each individual's brain is showing lower activation, and is it in these regions that other studies identified. After this, the resting state images will be taken after cannabis consumption. Images are taken when the brain is at its most dormitory state. These images will be taken every 5 seconds and will explore the brain regions that are active when the mind is unstimulated and just kind of wandering. It'll evaluate regional interactions in the absence of tasks. So after that, the task-based images will be taken. This is where visual stimuli is presented for the subjects. They read riddles. There's little distractions. It just explores the connectivity between the brain regions and their communication, and helps determine how a brain in a state of disorder functions differently than a normal one. So while the resting state shows, just what your brain's doing, when you're sleeping or resting, versus task-based, where you're doing things and your brain is actively thinking. So then after all the images are taken over the 6 days, the first images to be compared will be the original baseline images to the resting state and task-based. This will just be to see if there was any change. Did they increase? Did they decrease? Did they stay the same? Next, they will all be compared with the healthy control group. This control group will have no cannabis use and no bipolar disorder, just males and females of the same age range. This will be to see if they did they increase significantly enough to be to the control group? Did they increase significantly enough to be normal? And lastly, they will each of the administration routes will be compared to each other. This will just be to see, was it smoking or vaporization that had the greatest amount of effects? Did they all show the same amount of effect? Was there a difference at all? Some of the control variables in this study would be the participants, equal parts male and female in each treatment group, as well as ages 18 to 30. Just because bipolar disorder has an onset of late teens to early 20s, and so this would be the target group here. It would also be a blind study where the imager doesn't know which patients belong to which treatment group, just to avoid any bias. Cannabis composition will also have to be controlled for, I think this quote from Walsh et al., the different percentages of cannabinoids such as CBD and THC are some of the biggest distinctions between the different types, but the still debated botanical distinction between cannabis sativa and cannabis indica, with the former reputed to have more stimulating effects and the latter putatively more sedative, is one of the biggest determining factors. So one of the biggest problems with cannabis is that it varies so much. So we would use cannabis sativa because we want to have those stimulating, higher activating effects, as well as having similar moderate THC and CBD concentrations across the different treatments. Although it might not be exact, which could be a limitation. The time between onset and imaging will also have to be controlled for to ensure you're getting the levels of activation at their peak. Also, no outside THC consumption, as that could skew the daily use results. Some of the experiment limitations, many things can affect the way the effects from cannabis are felt. However, looking at the actual activation of the brain, I'm thinking that many of these wouldn't play as much of a role if there's an actual physiological effect going on. And as I mentioned before, cannabis composition could be a experiment limitation, though controlled for as much as possible. So if we accept the null hypothesis, it would signify no relationship between THC activating the receptors and the alleviation of symptoms if areas of low activation in bipolar patients either showed no change, decreased further, or increased slightly but not significantly compared to the control. So if there was a little bit of increase, this could be due to just the high that they felt or the alleviation of symptoms, but no actual increase in the brain activation. However, if we reject the null hypothesis and the images show that consumption of THC does in fact increase brain activity in these certain cortex regions to a normal level, the null hypothesis can be rejected and there will be actual scientific evidence for medical cannabis as a viable treatment for those with bipolar disorder. I think that this will be a profound discovery that will further support using cannabis as medicine, because it would be hard evidence that could be seen and not just anecdotal story evidence of people's symptoms being alleviated. But most importantly, it'll be crucial to those with bipolar disorder that are still looking for a treatment. There's 30 to 40% of individuals who can't find the right treatment will now have another option that won't be looked down upon or stigmatized. That is my experiment. I hope you enjoyed my video. I hope you learned something. I can't wait to hear from you guys. Thank you so much.